Good evening, everyone. This is Shreyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, let me welcome a very renowned doctor, Dr. Sunil Mahatai. Sir is MBBS MD Internal Medicine, DM, FRCP, London, consultant gastroenterologist at Medical Trust Hospital, Imakuram. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is gut instinct, a case based discussion on brain gut axis in functional GI disorder. Now, without any further delay, let me welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Thank you, Saran, for the kind introduction. Good evening to you all. This is a subject of interest to us, gastroenterologists, primarily because 80% of our outpatient clinics are actually brain gut access patients. So we have an interest in this to analyze what exactly is happening. This needs some personal care to the patient who comes in. So what I plan to do today with you is just go through the basic physiology, the anatomy, what is the basis of a brain gut axis, and the new one which has come into it is a microbiome. A huge microbiome has been analyzed in the GI tract, which is interacting with the body. So we will have a bird's eye view of all these things and then go into a few case discussions which manifest as irritable bowel syndrome. So what is this brain gut axis? Now, this is a complex two-way communication network between the central nervous system and the enteric nervous system. The enteric nervous system in the gut is no mean guy. It's a huge network. But then an interplay between the gut microbiota happens to the enteric nervous system also. A lot of signals come from the bacteria into the nervous system. So this travels to the central nervous system. And vice versa, from the central nervous system, it carries down into the gut. So does it get transmitted into the bacteria? We don't know. So we have four kinds of pathways where it does this function. One is a neural pathway, exactly an anatomical nerves which cables which go in. Then is an endocrine pathway which is mediated by hormones which are secreted by the gut or even the systemic hormones. The immune modulation, the immunity means the gut is the center of immunity. A lot of antigens exposure happen every day. And there is a lot of T cells, B cells, immunoglobulins in the gut. So this tends to react with the gut lumen, the luminal bacteria, as well as with the host. And then we have the microbiota, varied species, millions of them are there in the GI tract, starting from your mouth to your rectum. So because of this huge microbiota inside your body, there is a lot of interaction going on between the gut mucosa as well as the microbiota. Now see this is the enteric nervous system. You find the brain in the spinal cord here. This is the enteric nervous system is termed the second brain. That is primarily because 200 to 600 million neurons are there. Outside the central nervous system, gut is a thinking organ. That is why in English literature we sometimes say there is a gut feeling that something is going to happen. Sometimes you say, I can't digest what you're saying. What he means is I can understand, but it's a brain thing you're using there. So these things are gut related primarily because of the enteric nervous system. Now the neurotransmitters. Neurotransmitters are important primarily because we know that most of the anxiety, depression, schizophrenia, psychotic disorders, they are all mediated by neurotransmitters. And the neurotransmitters are actually inside you in a pattern, in a ratio. Now, this pattern and ratio of neurotransmitters is something which is replicated exactly like the brain onto the gut. So, whatever goes inside the The gut also thinks similarly. So if you're an anxiety patient, if you're a depressed patient, similarly the gut also behaves because the neurotransmitter pattern is the same. And you find there are a lot of ganglia, just see, a lot of ganglia, small mini brains outside the gut, which send signals into the gut. And then what you're finding with so many of neurons is going into the gut in the wall. What you're finding is very interesting. You're finding two layers of huge plexus. One is called the submucosal plexus or the plexus of Meissner, and the other is called the Meindrick plexus. Now, this is a huge network. You can see how intricate is the network. And this network, one controls the secretions and the mucosal activity, while the second one, the Meindrick plexus in the muscles, they control the movement. So the intestines know only two things actually. Intestines know how to move, how to secrete and digest and absorb. So these things, when they are altered by alteration of the enteric nervous system, patient gets to be a diseased person. So enteric nervous system is huge. You imagine such a network existing over 6 meters of the intestine. Apart from this, the gut has got an endocrine system. So we know recently there are weight losing injections available like Manjaro, semaglutide, liraglutide. Now they all work through the gut endocrine system. Gut has got endocrine, the newer hormones which have been described are the ghrelin, which is the appetite stimulant. If you have lots of ghrelin, you tend to eat more. The GLP-1, which is the appetite suppressant. The GIP-1, which is the appetite suppressant. So at least 12 different kinds of cells with many subtypes secreting lots of hormones have been identified in the gut, modulating the gut in different ways. It actually stimulates the movement, stimulates the appetite, stimulates the secretion. So the gut endocrine system is a big agent which the pharmacology targets to change the environment of the gut. Controlling satiety and eating behaviors and motility actually lies a lot in the gut endocrine system, but none are independent. They are all interdependent. The gut bacteria. See the gut bacteria. What all things they do? They do amino acid degradation. From tryptophan, they produce indole. From bile acids, they produce secondary bile acids from primary. They produce toxins, the polysaccharides. They produce short chain fatty acids from carbohydrates, and short chain fatty acids, incidentally, are the nutrition for the enterocyte and the colonocyte. That is a lining. So whatever undigested carbohydrates are there, the bacteria works on it and produces nutrients for the lining of the wall of the intestine. It's interesting how they live together. And the immunomodulatory mediators like sphingolipids and mucolipids. So gut bacteria produces all these kinds of things. And then how does the signal go through? The signal goes through by the gut microbiome producing all these chemical things like short chain fatty acids, secondary bile acids, tryptophan, that is serotonin. They all send signals up because they are capable of doing it. So they are sending signals up, they travel up the brain, you can see that, and then once it reaches the brain, modulation happens and signals come down. So the motility, the secretion, the kind of work the intestine does is completely altered actually by the gut microbiome. See the gut immune system. This is an entire world by itself. You see, we have a lot of T cells, the Th17 T cells, the memory cells. We have a lot of IgA, immunoglobulin A, which is a local protection. We have a lot of interleukins produced by small inflammatory cascades and cytokines which are produced by the gut immunity interaction in the lumen. So you're finding here, this is a lumen. This is a lumen outside with lots of bacteria and antigens. This is epithelium. And below that, in the mucosa, you find all these kinds of immune cells which are constantly on interaction with the antigens outside. They might be just protein antigens, they might be live bacterial antigens. So, thousands and thousands of antigens come in as you eat. So this is a complex system of activation in the small intestine or the stomach for that matter, which is transmitted up. So the gut immune system, the enteric nervous system, the gut microbiota, and the systemic hormones, the neurotransmitters, they all play a role in setting up the irritable bowel syndrome. So this is how it goes. Finally, as a small slide, if you summarize the gut microbiota, the microbe-derived molecules are there, gut-derived molecules are there. They produce neuronal, immune, neuroendocrine. All this affect the central nervous system, and they result in ANS modulation, autonomic nervous system modulation, and leading to motility, secretion, permeability, etc. And then we have the brain situations where there is a lot of stress, mood changes are there, sleep is there, visceral sensitivity, they may all get altered from the gut and vice versa from the brain to the gut. So, signaling mechanisms of all these can be either through, as you said, all these chemicals influencing the neuroendocrine cells, or these chemicals can cross the intestinal barrier also, and they can enter the systemic circulation. They can cross the blood-brain barrier, and then they can, by virtue of themselves, they can produce changes in the brain. So signals is one pathway, direct toxicity or direct actions are the next pathway. Finally, in the gut, it is either altered motility, altered secretions, and signals which create a haphazard nature of behavior in the gut, which leads to irritable bowel syndrome, the IBS. Now, it's very difficult when you analyze so much factors go into play there, which is exactly the cause of IBS. So we call that any of these can produce IBS or functional GI disorders. Now, a lot of other GI disorders, other problems, neurological problems have been identified with the gut related issues. Basically, the affective disorders, autism, Parkinson's disease, multiple sclerosis, chronic pain, the sustenance of chronic pain, they've all been linked to GI tract and the gut microbiome. So, let us take one. That was an overview for you to understand the complexity of the nature. It is not as simple as you sit there in the outpatient clinic and prescribe a medication, because there is a tailor making there. You may have to go into the history of the patient and analyze exactly what is happening. Where is the fault? Is it the neuroendocrine system which is the fault? Is it the gut hormones? Is it the nervous system? Is it the brain? Is there anxiety? Is there depression? So these things have to be analyzed prior to treating a patient. Let's enter into one scenario. This is a case-based scenario. A 25-year-old male IT professional. There's no prior medical history. He had to travel for professional reasons. Street food, lots of them were taken. He developed diarrhea, watery, with mucus and tenesmus. Tenesmus and mucus shows that it is more colonic in nature. It is not small intestinal. So something has happened into the colon. It is diagnosed was acute infectious colitis, and the physician whom he consulted put the patient on ciprofloxacin and metrogyl. This is a standard prescription throughout India, and the symptoms have subsided. Okay, fine. Now this guy comes back at home after 2 weeks. He develops intermittent abdominal pain in the lower quadrant below the umbilical area, and he passes semi-solid stools 2 to 3 times a day. In the past 2-3 months, he has been continuing with these symptoms, but his diarrhea had subsided. The only symptom left there is this. Now, stool tests are normal, colonoscopy is normal, because we have to investigate when a person says that he has got 2 months of abdominal pain with that feeling of urge to defecate and semi-solid stools. Fine. Now, this is called a post-infectious IBS. Now, we would think that probably his infection had not subsided, but his colonoscopy was normal, his stool tests were normal. So, this is a post-infectious IBS according to Rome 4 criteria. The Rome 4 criteria says that recurrent abdominal pain at least 1 day per week in the last 3 months, associated with defecation, change in frequency of stool, change in form of stool. Yeah, he fits perfectly with the criteria. And the symptom development immediately after resolution of acute infectious gastroenteritis. Yes, this guy had acute infectious gastroenteritis. Now, this diagnosis of acute infectious gastroenteritis has to be made either by stool culture or the symptoms like fever, vomiting, or diarrhea. And prior to that, he should not meet the criteria for IBS. So he should not have IBS prior to this development of this diarrhea. So this goes for a post-infectious IBS. This is a common scenario. People continue giving antibiotics. People continue to investigating, but it is a simple case of a post-infectious IBS. Now, why does this happen? Now, there is a change in gut microbiome because there is an invasion of a pathogen there. A pathogen has invaded and the microbiota has changed. Apart from that, antibiotics have been given. The good ones, which were protective, they were also killed. Now, then, the motility disturbance set up from by diarrhea is still persisting. That is why he has that abdominal pain with urge to defecate. And then researchers have found that there might be a low-grade inflammatory state existing. Sometimes, but in this case, a colonoscopy was normal. And sometimes a biopsy when taken, even if the colonoscopy is normal, you find mild inflammatory state existing post-infectious. So here, the treatment is not antibiotic. Once you treat the patient, I mean, once that infectious colitis is over, the antibiotic course is over, the treatment should rest on antispasmodics and like mebavirin, which relaxes the colon, and probiotics, increase the good flora in the intestine. So that is generally a better management strategy than a patient which has a lot of antibiotics or painkillers or I mean, whatever prescription which they sometimes carry is interesting. See case history 2. A 28-year-old female. She studied +2, lower abdominal pain intermittent for the past 2 years. 2 to 3 per week, she gets this abdominal pain. She has intermittent laxatives for constipation, occasional mucus. Sometimes she has to digitally evacuate. She has had urge to defecate with pain, and then once in 2 or 3 days, she passes a hard, lumpy stool. Now, hard, lumpy stools have been classified according to the Bristol stool chart as type 1 or type 2. So these show the Bristol stool chart is an excellent modality which says whether this patient has got diarrhea or constipation, because the consistency of stool, the shape of stool, they all are taken into account. And you find that lumpy and hard stools are type 1 and 2. That amounts to a constipated kind of stool. So this patient has got constipation with lower abdominal pain of long duration, 2 years, and with on laxatives. Now, this situation, we would call it otherwise, if uninvestigated as an outpatient, first diagnosis would be an irritable bowel syndrome with a constipation variant. Now, IBS has got a constipation and a diarrheal variant. Now, the constipation variant is compared to a chronic constipation or a habitual constipation. Now, habitual constipation will not have abdominal pain. So that is the difference. The main difference is a pain component. So habitual constipation is present, maybe even from childhood, but for long. Now, this, a workup is required, but because she is passing some mucus, a digital evacuation is sometimes required. So when we meet with an IBS constipation variant, 2 years duration, age is a criteria. If the age is above 50 years, definite investigation is required. But below that, maybe this 28-year-old lady, you may give a therapeutic trial, but still an investigation is required to have a foolproof diagnosis. A routine lab testing will tell you if there is some kind of eosinophilia, some kind of food allergy, if there is some kind of abnormality there. A celiac serology for definitely. You might wonder that celiac disease produces only diarrhea, bloating and diarrhea. No, they produce significant constipation also. The C-reactive protein to see if there is an inflammation. Fecal calprotectin study. Inflammatory bowel disease is a close differential diagnosis for IBS diarrheal variant or constipation variant, especially if you have mucus there. A complete blood count, a thyroid stimulating hormone, because TSH is simply enough as an outpatient thing, but thyroid stimulating hormone is a must for all constipation. Umpteen number of thyroids are being missed by just prescribing laxatives alone. Serum calcium. This is another component which controls the motility of the intestine. So, thyroid and calcium are important motility controllers. And a colonoscopy to identify if there is any anatomical structural alteration in the colon, like inflammatory bowel disease, like a solitary rectal ulcer, significant hemorrhoids because of constipation. Hemorrhoids primarily doesn't produce constipation, they are the sequelae of constipation. And then you find sometimes the pelvic floor dysfunction, where the mucosal prolapse is a one which creates a problem. So there are lots of things which you can analyze in this patient and tailor make her diagnosis of an IBS constipation variant and treat her likewise. Now, stool tests involved in IBS diarrhea. Now, the opposite of IBS constipation would be IBS diarrhea. Again, this patient has got pain with urge to defecate, and that defecatory stool is on Bristol 5 to 7. So it's diarrhea. Now, here, a stool examination is required primarily to rule out things which we might miss. And often the stool study which we do is just a stool routine and a stool occult blood. But that is not enough. We should do a routine and occult blood. Yeah, good. A calprotectin is very important if there is a protein losing enteropathy there. Stool elastase, if it is available, if you're working in a better facility, elastase will tell you whether the pancreatic function is normal and the patient is passing diarrhea because of that. A stool tryptase, this is even an more advanced investigation to see whether the stool has a serotonin mechanism there. Excess serotonin degranulation, for example, mastocytosis. Very typically a bit rare, but we find it in our more specialized practice. Sometimes tryptase becomes positive. Once or twice a year, you find patients coming with intermittent abdominal pain and diarrhea, long-standing because of this food-induced or stress-induced or other kinds of degranulation of the mastocytes or eosinophils in the gut, and the stool tryptase will be positive. I'm sorry. The blood tryptase is the one which is checked. It is not the tryptase in the stool. I'm really sorry. This is a blood tryptase. The cutoff value is 19. But elastase, it is a stool which is checked. The cutoff value is 200. If less than 200, it shows pancreatic insufficiency. More than 200, it is normal. Stool tryptase is not tested. It is stool chymotrypsin which is tested. That is a radio label test. So this is a typo error which happened from me. I apologize for that. Stool pH and fat globules. Now, a simple test for fat globules is a Sudan 3 staining, which your lab can do. And the pH will tell you whether it is an alkaline stool which comes out or an acidic stool. So that tells you about lactose intolerance or disaccharidase deficiencies. The parasites in the ova. Parasites in ova are very common in India still. So you have to rule out a patient with IBS whether there is a parasite and ova there. And sometimes specialized tests are also required. The routine might miss it. And in our specialty, we look for sometimes CMV, Clostridia in specific situations, patients presenting with abdominal pain, diarrhea of longer duration, 2 months, 3 months, and missed as IBS. So these things are ones which you have to keep in mind not to miss a pathology. Now, pharmacy and IBS, this is also very common. The diarrheal drugs, especially metformin, olmesartan, antacids, excess caffeine. See, metformin and olmesartan are very common prescriptions which can produce typical IBS-like symptoms. Antacids, excess intake, over the counter, excess coffee drinkers. Now, the constipation drugs, again, the antacids, a different kind. For example, if magnesium antacid produces diarrhea, the aluminum antacids produces constipation. The calcium channel blockers, most of the calcium channel blockers, we give the Nicardia, the nifedipine, all these drugs, the nitrates, the antipsychotics, the antidepressants, they all lead to sometimes constipation. So never miss a pharmacy-induced constipation because they are long duration. They're not once a day drug, or it's not a short course of drugs. They're all drugs which are taken for long. So that is pharmacy and IBS. Now the OP consultations for IBS. These are just clinical scenarios which we often find. For example, a child complaining of a toilet sensation and an abdominal pain early morning prior to school. There's no nocturnal symptoms. This is a common complaint which mothers bring children to our OP. Child is complaining of a toilet sensation, spending more time in the toilet, abdominal pain early in the morning prior to school. After that, the child is all right. The child has a good sleep. There's no problem. The next day morning, again, this recurs. So when this comes as a long duration, you should understand that this is also an IBS, but it is stimulated by a stress reaction of school. Now, patients with complaints of pain and defecatory symptoms just prior to travel, they are planning to go outside. They have to travel. Then they get that once more, I want to go to the toilet. There's a small pain coming up and relieved by defecation. So this kind of intestinal hurry is a part of our lifestyle also. The there's an old sentence which my professors used to say, hurry, worry, and curry. So hurry, worry, and curry, they all lead to IBS. Now, the obvious stress or tension feel evoking a colonic symptoms the patient often narrates to you. See, when I get it, the stress, I want to go to the toilet. When I'm angry, when I'm depressed, when I'm emotionally upset, I want to go to the toilet with an abdominal pain. So these are OP consultations or IBS for which we generally, if the symptoms and clinical scenarios are straightforward, we do not investigate a lot. We try treatment first and then decide whether you have to be investigated if the symptoms are persisting. I think that is possibly my 25 minutes of it. So I should thank you, IJCP, for the invitation, for being a speaker for IBS on the IBS Awareness Week. Thank you very much.
Hello, sir. Thanks for this wonderful presentation. We do have some question if you like to take that up.
Yeah, sure, please.
So, sir, the first question is, how do you explain the functional diagnosis to patients who may expect a structural cause of their symptoms?
It's a good question. See, that is one thing which our practice is all about. So, if a patient has already been suffering from the symptoms for long, then definitely it is better to investigate and reassure the patient that there is no problem there. So, the structural problem has to be evaluated by a colonoscopy or stool test. But suppose this patient has got a short duration of symptoms. For the first clinical scenario I told you, over 2 weeks, he had a diarrhea and then now comes with about one or 2 months of a short duration of symptoms. Unless the patient is anxious and requests to be investigated, we can always have a window of a therapeutic trial. So it is up to the doctor to decide whether it has to be done. Reassurance is always a good mode, definitely a good mode. Though Rome 4 says that a positive diagnosis of IBS could be made, in clinical practice, it's generally always a diagnosis of exclusion after doing all the tests.
Next up, sir, what is the role of gut-directed psychotherapies like CBT or hypotherapy in managing this condition?
Hypnotherapy. CBT is cognitive behavioral therapy. Yeah, cognitive behavioral therapy and hypnotherapy are good modalities. Actually, they are good modalities. The cognitive behavioral therapy actually gives you feedback. Um, uh, the they are basically, we use that for constipation of pudendal dysfunction, pudendal nerve dysfunction, and pelvic floor dysfunctions. See, when a patient has got uh, hasn't had a proper toilet training. They exactly don't know when to apply the squeeze and pass the stool. So we do something called biofeedback therapy, the cognitive behavior therapy, that is making them understand the physiology behind a defecatory process and then give them a feedback. So often the biofeedbacks are done by putting a small balloon in the rectum. We inflate it and then ask the patient to perceive the sensation. So only when the patient perceives a sensation well, does she have to squeeze on it. He or she has to squeeze on it. Now, when the squeeze is on, we can always give them images of how the balloon is traveling down. So this is kind of biofeedback, giving them an insight of what is happening into the rectum or gut motility so that they don't squeeze unnecessarily and keep on doing it. Sometimes people think that it is their squeeze into their own effort which makes the stool pass. It is not. The intestines have to do their own work. They have to move well, bring the stool down into the rectum, and only then you open up the external sphincter. Primarily, people start squeezing from the morning because that is what they have heard. They have to pass stool, otherwise everything will be in a disarray. Actually, it is not like that. So CBT, the hypnotherapies, the biofeedback mechanisms, they all work. So it is all tailor made to teach the patient how things happen inside your body.
There is one last question, sir. What are the common pitfalls physicians face when managing functional GI disorder, and how can they be avoided?
The common pitfall in functional bowel disorders sometimes, let us start from an outpatient patient. A patient comes to you, you do not have much time to analyze the patient. So you give a prescription and send them off. If a follow up is there, it is well and good. If the follow up is not there, you have not analyzed the patient properly. That is the number one pitfall. So, spending lesser time with the patient, understanding what is the nature of the disease. Two, if an investigation is needed, you have to order the proper investigation after hearing it. A proper stool examination and a sigmoidoscopy often is enough. Generally, you don't have to go for a major investigative procedure like a colonoscopy or all the stool tests which I put it as a slide. You don't have to. You just do a stool routine evaluation and an occult blood and then do a sigmoidoscopy. 90-95% of your patient analysis is over. Then take a good history. So pitfalls happen there. Now, the red flag signs, if we ignore, the red flag signs is a mucus passage, and never attribute a bleeding PR to a hemorrhoid. Oh, now you have constipation and you have got a hemorrhoid. So pitfalls happen when you're ignoring the red flag signs. Any abdominal pain which is severe, which is disturbing the patient's sleep, which is producing weight loss, which is producing intermittent bleeding per rectum. So all these things are important. And if the patient has got a family history, so these things have to be analyzed during your history taking. And once you decide on that, give a decent examination, then we can avoid the pitfalls. And then over pharmacy. So whenever a patient complains like this, you put them on an antibiotic, you put them on a painkillers. So often the painkillers which are given are NSAIDs. NSAIDs are the ones which are sometimes prescribed for abdominal pain of IBS. The patient comes with a dyspepsia later because of NSAID-induced gastropathy. So choose your drug well and make sure that do not prescribe antibiotic unless otherwise it is required. So all these things are the pitfalls which I can possibly narrate from outpatient practice.
Thank you so much, sir, for answering all our questions. That's all from our audience. Sir, before concluding, any take home message from your end?
Take home messages is because IBS is something which is very common in our society, in our outpatient practice, and probably the basic clinical practice in abdominal symptoms revolve around IBS. I would suggest that make sure a stool examination is done for all the patients which you come across, because it can be done in a very inexpensive way. If you have any doubt, refer to a gastroenterologist nearby to make sure an investigation is done and do not miss something which can be treated early. So IBS, though the Rome 4 criteria says it is a diagnosis positive which can be made in the outpatient clinic, please do not play with it and make sure that if it is not responding to the kind of treatment you have prescribed, refer to a gastroenterologist for further workup. That should be the message of the day. Thank you.
Thank you so much, sir, for this session, and thank you for joining us today. It's our pleasure to
Yeah.
have you here. Thank you so much, sir.
Yeah. Okay then. Bye.